rostrum, we have an iliosacral joint, and we have a sacral-iliac joint. There's a coccyx. The thigh is comprised of the femur as well as the patella. So when we talk about joints of the lower extremity and we say we have a
Professor, can you share your screen?
I'm sorry?
Can you share your screen?
Oh, I did. Okay, Jesus. I did, and okay. There. You got it? Now? You see it?
Yes, we can see it, yes.
So now let me move you guys out of here. And, alright. And I sent you this also. So when we said, when we look at the hip, we look at the aftertabular femoral joint because we name the joints from proximal to distal. And we talk about the knee joint, we say we have the femoral tibial joint. A lot of therapists say tibiofemoral. And we have a patellofemoral joint. If we move distal down the extremity, we have a talar-crawl joint, a subtalar joint, mid-tarsal joint, metatarsal phalangeal joint, proximal phalangeals, distal phalangeals, right? So in the leg, we have the tibia, the fibula, the 7 tarsal bones, and what are the names? Anybody? Calcaneus, talar,
Navicular, cuboid,
and the 3 cuneiforms.
Cuneiforms, right. We have the 15 metatarsals, 5 metatarsals and 14 phalanges because the great toe only has a distal and a proximal, right? Okay. Now, when we talk about classical patterns for lesions of contractile or nervous tissue, we're going to talk about what we do as therapists and how we determine if somebody's got a musculoskeletal problem. And we look at specific isometric contraction. So we put the person, we place the patient in flexion. We could do a quick test, or when we talk about manual muscle testing, we could do an isometric contraction, or we could do a contraction through the range of motion. So possible responses, if we're going to test a limb, let's say the lower extremity, and it's strong and painless, then we can make the determination that there's no pathology with that musculotendinous structure, okay, if it's strong and painless. If it's strong and painful, then we can say there's a minor lesion at that musculotendinous junction. So that can be referred to as the cause of the etiology can be a tendinitis or muscle strain. If it's weak and painful, so we test the limb, it's weak and it's painful, there's some kind of a serious problem. So maybe it would be like a cancer, some kind of space-occupying lesion. An example of it would be a fracture. And how would we test if this was a superficial bone or a superficial area, and we wanted to determine whether it was a fracture, we could use a tuning fork. Something deeper, we cannot. We have to refer the patient out and ask him to go for x-rays. If it's weak and painless, it can either be a complete tear of the muscle, and there's no nerve that is supplying the structure itself. So these are things named by Syriac that we follow when we're going to determine are we dealing with something that's a minor lesion, a major lesion, or complete rupture in referring to muscle. That applies with any joint. When we talk about the hip, we talk about the fact that it's a triaxial joint and it moves in 3 planes. Generally, range of motion of flexion of the hip is approximately 100 to 125 degrees. Extension is anywhere between 15 and 20 degrees. There's variations to that. We call extension the same thing as physiology people call hyperextension, because really extension is just returning, according to the definition, extension is just returning from flexion. So hyperextension or extension, as we would call it if we were measuring the joint, would be about 15 to 20 degrees. How would we measure this? We would have to put the patient in prone to measure extension. Okay? Because what is the definition of flexion and extension? It's movement in what plane? Sagittal plane through what axis? Coronal axis. Can we measure this person in prone with the leg coming off the mat? Yes, if we have to. It's not ideal because we want to ensure that the person doesn't fall off the mat, but we could do it. Abduction and adduction in the limb. Abduction is approximately 45 degrees of hip abduction and approximately 25 degrees of past midline. So we have a midline, and we would we would have to move the leg away. So we would have to move this, if this person was supine, we would have to move their left leg away, bring their right leg with their left leg, and then we could measure. Somebody get, not muted?
Okay.
Somebody talking to somebody? Anybody recognize that voice?
Okay, so in December?
Yeah.
Okay, no problem. Thank you for reading me.
Having a conversation.
Can everybody mute their mics, please?
Okay, so with lateral rotation, remember that's used interchangeably. I tend to say external and internal rotation. It's the same thing. External rotation is lateral rotation. Medial rotation is internal rotation. So we have approximately 45 degrees of internal and external rotation. When we talk about the hip, remember we said specifically when we talk about the capsule of the shoulder, and we said the capsular pattern was what? Anybody tell me? What's limited greater?
ER.
ER is limited greater than abduction, which is limited greater than internal rotation. As a rule, a lot of people, but you'll see variations in this too. Some books will say internal rotation is limited greater than flexion, which is limited greater than abduction. And that external rotation isn't limited much at all. Because when we're in a resting position, or think about yourself in a bed at night, your foot is usually plantar flex, your hip is usually laterally rotated. So that's a loose, packed position. So that is not something that really becomes involved in a capsular pattern. Usually it's internal rotation, flexion, and abduction. Sometimes people say abduction before internal rotation, but generally as a rule, that's what you're going to see. And a limitation in internal rotation, hip flexion, and abduction. So that's with a capsular pattern. So that capsule is a large, thick, cylindrical, connective tissue that is surrounded, that supplies, that goes from the acetabulum and to the neck of the femur, and also encloses most of the femoral neck. Okay. Acetabular labrum, just like in the shoulder. Is the labrum as important in the hip? It is, but it's not in the hip itself, as you learned this morning and yesterday. There's that rotator cuff muscles of the hip, all the deep external rotators that attach. Where do they attach mainly to? You remember that from this morning and yesterday?
Greater trochanter.
Greater choke.
So they really, really help support the hip. So those muscles are very important in actions of what is going on in the hip itself. The acetabulum of the hip is much deeper than it is than the glenoid fossa of the shoulder, but we still have this fibrocartilaginous labrum that surrounds it, and it assists in helping that head stay into the acetabulum. So for the lumbar plexus, there's all kinds of mnemonics out there. I just happen to use this one because when we refer to lumbar plexus, these subconsole and the hypogastric levels are usually more sensory in nature. So we'll talk about the I think I spelled that wrong. We know femoral, lateral femorocutaneous, obturator, and femoral nerves. These are more of the lumbar plexus, but we usually combine them to say lumbosacral plexus, and there's a lumbosacral junction. And in fact, when we talk about the sciatic nerve, we say it comes from the lumbosacral plexus at the levels of L4 to S3. So there's the lumbar plexus itself is going from T12 to L4. We could see here that these specific muscles are more sensory in nature, as well as the lateral femorocutaneous. This is purely a sensory nerve. Obturator nerve and femoral nerves, as we know from lab this morning and yesterday's lab, the obturator nerve is coming from the levels of 2, 3, and 4 on the anterior divisions, because we have an anterior and posterior division of the lumbar plexus, and the femoral nerve is coming from the posterior division. Femoral nerve is innervating mostly what? If we think about where this nerve comes from, it passes under the inguinal ligament and innervates mostly the muscles of the anterior thigh. Yes. Somebody have a question? Mostly the muscles of the anterior side. The obturator nerve is coming down from the lumbar plexus on the medial side, mostly innervating all the muscles of the medial leg, which are the adductors. Okay. Sacral plexus involves some idiots sit pondering pervertedly. So superior gluteal nerve, what does that innervate? Anybody remember? What's the superior gluteal nerve innervate? Superior gluteal nerve innervates the gluteus medius and minimus, right? As well as the TFL. The inferior gluteal nerve innervates the gluteus maximus. Sciatic nerve innervates everything. You guys that were in lab this afternoon, and I know you that are having lab tomorrow will see the cadaver dissection, so you can actually see the size of the sciatic nerve. It's one of the largest nerves in the body. Coming out of the greater sciatic notch, runs down, usually posterior to the piriformis. Most people it does. Then it runs between the lateral to the ischial tuberosity, medial to the greater trochanter, comes down the leg in the posterior fashion, throws off a branch of common peroneal and the tibial to the adductors and the short head of the biceps, goes to the popliteal fossa, at which point it splits into the common peroneal nerve as well as the tibial nerve. The common peroneal nerve goes around laterally to the fibular head, where it splits into the deep and the superficial peroneal nerve. The tibial nerve continues down posterior to the lower leg before it goes between the flexor digitorum longus and the flexor hallucis longus, spirals around the posterior area of the medial malleolus before it branches off into the foot and becomes a lateral and medial plantar nerves. The common peroneal splits into the superficial and the deep. The superficial stays laterally to innervate the peroneus longus and brevis, and comes around anteriorly to innervate the deep dorsiflexors of the foot. So, without the sciatic nerve, guys, what can we do? Not much, right? Sciatic nerve is a very large nerve with a lot of innervations. So posterior femoral cutaneous, again, it's just a cutaneous nerve and a pudendal nerve. Okay. So lumbar sacral plexus, as we'll call it, is divided into two plexuses, the lumbar plexus as well as the sacral, and it receives innervation from, many muscles receive innervation from both of these plexuses. Lumbar plexus L1 through 4, innervating the thigh muscles, and sacral plexus L5 through S3, innervating the leg and the foot muscles. So, having said that, it's a little bit more difficult. It kind of looks like this. It's not as I think that the brachial plexus is much easier to understand than the lumbar sacral plexus, but we're going to try to make it as simple as possible. This is what the lumbar sacral plexus looks like.
10.
So we could see iliohypogastric, ilioinguinal, genital femoral, lateral femcutaneous, femoral obturator, lumbar sacral trunk, superior gluteus, inferior sciatic, comprised of both. These two are in a common sheath, posterior femcutaneous, etc. So I took this and did this. Lumbar sacral plexus. If you follow this, it should be pretty easy.
11.
L2, 3, and 4, the posterior divisions from L2, 3, and 4 form the femoral nerve. The posterior divisions from L2, 3, 4, Joe, stop yawning, form from the anterior division, form the obturator nerve. Okay? The posterior divisions of L4, L5, S1 form the superior gluteal nerve, and the posterior divisions of L5, S1, and S2 form the inferior gluteal nerve. The common peroneal nerve, the sciatic nerve, is from L4 to S3, but the common peroneal nerve is posterior divisions of L4 to S2, and the deep and superficial peroneal nerve are down here from S2. Tibial nerve is from L4 to S3. So if you just look at this and just take a little time to review it, it should make sense to you. Okay? So femoral nerve coming from the posterior divisions of these three roots. So all you have to know is the femoral nerve is coming from L2, 3, 4. So is the obturator nerve. Superior gluteal nerve is coming of L4, 5S1. Inferior L5, S1, S2. Okay, sciatic nerve coming from L4 to S3. All right? It's much easier than trying to understand it through that picture. And again, there's a lot of nerves that we don't really come into contact with because, and I will tell you that the lateral femoral cutaneous nerve is probably the only one that we'll be talking about because that has a clinical relevance. But the other ones we're really not dealing with. Okay? So if you want to go ahead and learn those, all the rest of them, that's fine too. But you're not going to be tested on it. Okay?
What was the one you said is of the most importance to us, Professor?
The femoral, the obturator, superior glute, all of these, except for this one, lateral femoral cutaneous nerve. But that's in a different slide. So the lateral femoral cutaneous nerve is purely cutaneous. It's purely sensory. It doesn't have a motor component. Okay? Just as the saphenous nerve, which is a branch of the femoral nerve, which is purely sensory. Okay? So just bear with me. We'll go over that individually. All right. So lumbosacral plexus. And here, this is a really simple. What I said to you,
12.
and I put it in writing also. What I said to you about sciatic nerve comes from the lumbosacral plexus from the level L4 to S3. Sciatic nerve comes out the greater sciatic nerve, goes posterior underneath the piriformis in most people, comes midline down the thigh, lateral to the ischial tuberosity, medial to the greater trochanter, sends some fibers from the common peroneal and tibial into both the adductor and the short head of the biceps, goes to the popliteal fossa, splits. It's all in writing. Okay? This, I think it's a little, hold on, this looks a little screwy to me. Oh, I think these arrows moved. So we have the femoral nerve, we have the obturator nerve. This medial plantar should be over here. I'll correct this and send this back to you, okay? So the sciatic nerve has a common peroneal and a tibial nerve. And then the common peroneal branches off into the superficial and deep, and the tibial nerve branches off into the medial and lateral plantar, and they service the foot. Okay? So we have a sciatic nerve in the thigh. As it reaches the knee, it branches off into a common peroneal and a tibial. Some people, by the way, call this common fibular and superficial fibular. I want you to know that because I think your trail guides say that. And I think they still use this on the state board exam, but in the event that they change it, you'll know common fibular is the same thing as common peroneal, common peroneal. I use that word interchangeably, sorry. You could say it however you want. But sciatic nerve branching off at the popliteal fossa into these two nerves, tibial and common peroneal, tibial branching off at the leg, at the bottom of the foot, behind the medial malleolus, and then continues at the medial and lateral plantar nerve, which, remember, we have the ulnar and the median nerve in the hand, right? Ulnar nerve serves the medial side, and the median nerve serves the lateral side, right? Okay. In the foot, the medial plantar nerve services the medial side of the foot, and the lateral plantar nerve services the lateral side of the foot, just like in the hand. And we have the same muscles. So we have the lumbricals, we have the dorsal interossi, and we have the plantar interossi. The common peroneal at the level of the popliteal fossa splits into the superficial and deep. The deep is really important because that comes around to the anterior side of the leg and innervates the anterior tibialis, the extensor digitorum longus, all those muscles that perform dorsiflexion. So if there was a test question, which I always put, if I had damage to the sciatic nerve above the knee, what couldn't I do? Probably nothing, right? If above the knee, because then the tibia will be out, the common peroneal will be out. But what if I said, because I just told you guys that the common peroneal nerve wraps around the fibular head, and that fibular head is really important. If you remember from day one, when we were in lecture, or lab rather, we palpated something at the fibular head. What did we palpate? We palpated the fibular head, but why did we palpate it? Anybody?
Heads of the quad or the hamstring.
Because of the biceps femoris. Remember that the biceps femoris attaches to the fibular head and the lateral tibial condyle, right? So the biceps femoris, if we had a fracture of the fibular head, we could actually have damage to the common peroneal nerve. If we have damage to the common peroneal nerve, what do you think we wind up with? What did I say the deep peroneal nerve innervated? Anterior tibionalis muscles on the anterior side of the lower leg. What do? Dorsiflexion. So if I had damage to that nerve, what kind of a gait pattern would I have? We've talked about wrist drop. What do you
drop foot.
Drop foot, right. And drop foot would occur with damage to that deep peroneal nerve or that common peroneal nerve. Absolutely. Okay? And what do you think the myotome is for the lower extremity? Didn't we do those? We did, didn't we? We did myotomes for upper. Did we do myotomes for lower yet?
No.
A little bit.
No, a little bit. No.
Part of the dance. I don't think we
Did we go over all of it?
How could you dance without knowing the myotomes and dermatomes? You guys are terrible. You haven't danced. I've always seen, Casey's going to get his due. Casey will definitely get his due. And so will one of the lab classes, but I've seen nothing from anybody else. So you guys should know your dermatomes for the lower extremity, and you should know your myotomes for the lower extremity. What did we say myotome was for L4? Myotome for L4, anterior dib, dorsiflexion. So how do we test that? We ask somebody to walk on their heels. You ask somebody to walk on your heels, you're testing what's happening at myotome associated with that level, those roots. So L4, L5 person, HNP, L5S1. What's the myotome for L5?
great toe.
Great toe extension. What's the myotome for S1?
Plantar flexion?
Plantar flexion.
Plantar flexion and eversion. Eversion is easier to test when you're in plantar flexion is really difficult to test if you're having somebody lie down and push against you. How is it more effective to test? What do you think?
Walk on the ball of the feet.
Walk on your toes, right. So we test L4 by walking on the heels. We test L5 by just great toe extension. What do we have to worry about during great toe extension? That they're not doing dorsiflexion. Different levels. Dorsiflexion is L4. Great toe extension is L5. So when we ask a patient to extend their toe, we're looking for their toe extensors to actually come into play, and not the continued action of the dorsiflexors of the anterior tibialis. Okay? So, spinal nerves, here we see them. Sciatic nerve, large, very, very large nerve. L4 to S3. Important.
13.
Okay, very important. Alright, so here I have it all written out for you.
14.
L1 to L4, just the same thing I said. Lumbar and L5S3 sacral plexus. Sciatic nerve injuries from L4 to S3. It's the largest nerve in the body. Obturator nerves coming from the anterior division. Femoral nerves coming from the posterior division. The tibial nerve and the common peroneal nerve are together in this connective tissue sheath in the thigh as they throw off some branches to both the biceps as well as the adductor. Remember, the adductor magnus is innervated by sciatic as well as obturator. Tibial nerve is the anterior division and it's innervating the muscles of the posterior leg as well as the sole of the foot, because the tibial nerve continues as the medial lateral plantar nerve. The posterior leg muscles, what comprises them? You guys should know. I would assume that, who is it? Who is it that tells me all the time how muscular they are? Devin. Devin.
Yeah, what's up?
What can you say about the muscles innervated by the tibial nerve? You have any?
All of them.
Oh, I know. Okay, so we're talking about that gastrocnemius. We're talking about that soleus.
Oh, I don't have those. I just have above the knee and up. Your feet toes.
Okay, so you have no gastrocnemius. I would imagine that Joe should have a pretty decent gastrocnemius and soleus because he spends a lot of single leg stance on. Do you do single leg on the skateboard?
Yeah, pretty much most of like the push. You know, you're bouncing on the one leg.
The single leg is mostly soleus involved in that, but there is because the single leg soleus actually studies the femur on the talus. I'm sorry, the tibia on the talus.
Now, would you have a more pronounced gastroc on one side, or do you push bilaterally?
Well, we'll do that when we do manual muscle testing next semester. Hopefully, we'll be back in school. All right, so the common peroneal nerve is the posterior division and it innervates the short head of the biceps. The tibial nerve will go and innervate the adductor. So superior and inferior gluteal nerves come from the posterior division of L4 to L5, the superior and the inferior from L5 to S2. Inguinal ligament is something and it's really just there because it's really important. It separates the abdominal wall from the thigh, and its importance for us is knowing that there's a change in that vasculature and nerve, etc. So there's an external iliac artery, vein, and nerve that is proximal to this inguinal ligament, and then as it crosses under the inguinal ligament, it changes its name to the femoral artery, vein, and nerve. Femoral artery and vein continue on down to the adductor. The adductor magnus has within it something known as an adductor hiatus, and it's a little space through which the femoral artery and nerve exit and it changes its name to the popliteal artery and vein, but also running through the adductor hiatus is a saphenous nerve, which is saphenous nerve. I'm sure you've heard of the saphenous artery, saphenous vein. They do, when they do bypasses, they work with the saphenous vein. But the saphenous nerve is purely sensory nerve that innervates the anterior medial, posterior medial musculature of the hip. Okay, so we have that inguinal ligament. The ischial tuberosity, as we know from our bony landmarks, is located in the middle of the butt, and it's at the level of the gluteal fold, and that's how we found it. Sciatic nerve lies here. Remember I said it's lateral to this. So what we don't want to do here, and we're not physicians, but what we don't want to see done here is an injection. Okay, injections that are done in the butt are done in the gluteus medius. And the reason they're done in the gluteus medius is to make sure that you don't hit the sciatic nerve through the gluteus maximus. Okay? So piriformis is located here. Remember I said piriformis lies over the sciatic nerve, and that sciatic nerve is common midway between the ischial tuberosity and the trochanter. Okay? And I know you guys, I'm sorry we started late and it won't happen next time because we kind of got this test down, but if we look at this, what I want you to know, if you don't take away anything, I want you to know this for when you come back. I want you to be able to tell me the course of the sciatic nerve. Okay? I want you to be able to tell me this. So if we look here, tibial nerve, it says here, tibial nerve divides into the medial and lateral plantar nerves. Common peroneal nerve divides into the superficial and deep. I wrote down word for word what I just said to you. Okay?
18.
This is the course of the sciatic nerve. All right? So I want you to know the course of the sciatic nerve. If you have any questions, just email me about it, but this is important, okay? And we'll talk more about that, and we'll continue down, and we're also going to videotape, Mrs. D'Onofrio has kids that come home from Thanksgiving. We're going to videotape them with special tests. We're going to expect you guys to videotape each other or someone in your family performing a special test. And that's all we could do this semester at this point. Okay? Any questions? Because I know you have to go. I know some of you have stuff to do.
Professor Stutz-Doyle.
Yes.
Thank you. So for those special test videos, when would you send out hey, we're gonna do it this day, and then submit the video this day, or how would you work that out?
Well, what we're trying to do now, we're trying to get some special test videotapes for you. I think we could hopefully we could do them by tomorrow night. And if we can do them, we'll send them all out to you. We want you to watch them. If you want to take it upon yourself to practice them, again, do not practice these tests with somebody who has the pathology, because we don't want anybody getting hurt. So if there's somebody else in your family that can help you out and say, hey, I'll do this. I mean, the shortness of a muscle is not going to hurt anybody. It's just you may actually feel good. But, and then any of the tests we're doing are not really that invasive anyway at this point. But 90-90, to look at the length of the hamstrings. Overs, to look at the length of the abductors. Thomas test, to look at the length, IT band. Thomas test, to look at the length of the rectus, the TFL, and the iliopsoas group. And was it made clear yesterday? I think it probably was, but I'll just repeat. With the Thomas test, if the side does not approximate the table, it is an iliopsoas issue. If the tibia is not perpendicular to the floor, it is a rectus femoris issue. And if the leg is abducted, it is a TFL issue. Okay? And I think that when we do the video, we'll talk through it so that you'll have a little more information and you can understand it.
Sounds good, thank you.
Okay? And any other questions?
For next week, since we don't have class on Thursday, what's going to be on the muscle quiz? Just the ones we learned today and yesterday, or?
No, those of you who were in lab today know that there's a lot more muscles that you're going to have. You're going to learn those of you who are in lab tomorrow, the adductors will be added, the hip flexors will be added, the knee extensions will be added, and the knee flexors will be added. So all the hamstrings, all the adductors, all the abductors will be added, and you'll have to know. I think there's probably about, what do you guys think, about 20 muscles?
It's not like 70.
It's 26.
26 muscles. Okay. 26 muscles. And I don't know if Kevin reiterated it with you guys or even said anything to you guys, but on 12/10 we will have the practical exam. On 12/15 we will have the lecture exam. And on 12/17 we will have the final exam. Okay? So, again, I tried to put all this, but usually I just talk about it in class, but I tried to put it all down in writing for you to try to figure out where this is. You're only responsible for what's on these slides, but you are responsible for the course of the sciatic nerve. That's a big thing. Okay?
Wait, can you tell us the days we have our exams and practicals?
I wrote them down. I'll send them in the chat.
Okay. The practical is 12/10. Your lower extremity exam is 12/15, and your final is 12/17, because that's the last day of class. Okay? I think, as an instructor, the lower extremity is much easier. So you guys do a lot of different nerves you had to know, and a lot of different origins, insertions you had to know for the upper. The lower extremity is much easier. The muscles are much larger. and the insertions are much more common, and the origins are much more common. They share a lot with one another. So I think it's easier to learn the lower extremity, including the nerves. I mean, we're talking about obturator, femoral, sciatic, deep peroneal, superficial peroneal. That's it. We're not talking about, so many thoracodorsal, dorsal scapular, spinal accessory, blah, blah, blah. So I think you'll find it easier. If anybody has any questions or concerns, please email me. I'm going to I was going to send you out with your ID numbers all your grades, but it came to my attention that some of you know other people's ID numbers, so I can't do that because of privacy. So please email me if you want to know your grades. I'll have them all done by tonight, and I will provide you with your practical grade and your lecture grade and your last quiz grade. Okay?
Thank you.
Okay. So,
Will our overall grade that you will tell us include the last, the quiz from today?
as long as it's corrected, yeah. As long as it's corrected. And it should be, because Kevin has some kind of, program or something to correct them. That's much easier than what I had to do when I corrected your last test. That's why we asked you to go in to make sure that we didn't miss anything. Okay? All right, so have a great holiday. I won't see you until following Tuesday. So enjoy your Thanksgiving. Stay safe. Don't do anything crazy.
Thank you, Professor. Thank you.
Take care. Bye-bye.